Hi, I'm Dr. Chuck Murphy, and I'm at the Inova Heart Recovery Symposium, and I'm joined by Dr. Navin Kapur from Tufts. Dr. Kapur, welcome.
Thank you.
I'd like to talk to you about some of the exciting things that are occurring in the area of cardiogenic shock, and you're certainly a leader in that field. Maybe we can start out by talking about the importance of door-to support.
Yeah, so there's been quite an evolution over the last few years, focusing on the idea of using mechanical support in cardiogenic shock. We've seen a lot of data come out over the past decade about intra-aortic balloon pump. We're seeing emerging data around the use of Impella and transvalvular technologies. ECMO is another interesting platform that's used quite a bit. But the overall theme that we're seeing is that when we have somebody coming in cardiogenic shock, the focus is beginning to go towards hemodynamic stabilization. And as we said, there are several ways you can do that, but there's also a very important timing element. And one of the most important aspects of the door to support concept is the idea of taking a patient with cardiogenic shock, stabilizing them hemodynamically using these technologies as quickly as possible and as appropriately as possible, meaning that you want to get the appropriate technology and combination of technology to stabilize the patient. And so that door to support concept really hits home that timing is the most important element here. Just like the evolution of the field of acute MI management was radically changed by the door to balloon time, very similarly, we think that cardiogenic shock will have a much better prognosis if we focus on a door to support time. And the target we're looking at is ideally a door to support time of less than 90 minutes from initial presentation in cardiogenic shock to provide hemodynamic stabilization.
And then I think one of the other important aspects of this is really developing and using algorithms to support these programs.
Yeah, so the algorithm growth I think is really critical, and the National Cardiogenic Shock Initiative is sort of one of the first algorithms to prospectively test in a registry fashion what is the effect of timing. And so what Dr. O'Neill and his colleagues have done is essentially taken a lot of the fundamental knowledge we've gained over the past 5 to 10 years and use that knowledge to then put together a very simple algorithm that allows us to have a couple hemodynamic metrics to make a go versus no-go decision around the use of mechanical support in shock. But the algorithms still have to evolve, and I think it's not only the decision-making algorithm up front, it's also the intra-procedural algorithms on technical implant and how to make sure that that's done optimally. And then almost as importantly, maybe more importantly, is the post-procedural management algorithms. When we hand the patient off to the intensive care or critical care teams, how do we identify who's actually recovering, who needs more support, when to escalate therapies, and when can we wean therapies? And so I think those algorithms are still very much in development. But on the front end, the first step is trying to get an algorithm to improve survival by focusing on early hemodynamic support, and that's where the National Cardiogenic Shock Initiative is pushing in that time metric.
And then I think some of your work is very exciting in the area of longer term outcomes. So maybe you could talk about, not only the outcomes during that hospitalization, but the longer term prognosis.
Yeah, absolutely. So I think, as we start to learn more about mechanical support, a lot of the acute mechanical support world is following in parallel in growth to our experience with durable VADs and durable mechanical support. We've seen those technologies on the surgical side advance quite a bit from pulsatile devices to continuous flow pumps. Now they're looking at longer term implants and what are the implications on cardiac and hemodynamic stabilization. Very similar in parallel, we've gone from pulsatile balloon pumps to now continuous flow transvalvular pumps like the Impella, and now we're looking at what is the impact of putting an Impella in up front on the downstream effect on the heart and its ability to recover. And so going from durable VADs, which are cardiac replacement strategies, to temporary support systems, which are cardiac recovery strategies, there's a lot of work to be done there. And I think cardiogenic shock is one area where we're seeing some traction, and we're hoping to see some really good positive results over the next couple of years. But also just an acute myocardial infarction, where we see patients come in, get primary reperfusion therapy, and still have a residual infarct. One of the holy grails for cardiovascular medicine is chasing the ability to reduce myocardial damage. We know that we can do that to a certain degree by reperfusing the artery. The question is now, can we harness the power of these mechanical support options to reduce the mechanical workload of the native heart and thereby enhance the recovery process. And that's some of the exciting data that we hope to see more transition from the preclinical work to the clinical work over the next 3 to 5 years.
Well, you really gave a tremendous, phenomenal keynote address, and we really appreciate you being here at the Heart Recovery Symposium. So thank you very much for your time.
Great, thanks for having me.